Hi everyone. In this video, we will talk about liver anatomy, the basics and beyond. The topic sounds basic, but we are going to see it from a surgeon's perspective. This lecture was supervised and prepared by Dr. Hiba Tahir, consultant pediatric surgeon at Cairo University, organized and presented by me, Dr. Ahmed Amgad, a fourth-year medical student at Hilwan University. First of all, we are going to start with the gross anatomy of the liver. The liver is the largest solid organ and gland, with its large right loop in the right hypochondrium extending to the epigastrium, and its small left loop in the left hypochondrium lying mainly under the rib cage. And in order to have optimum surgical access, we perform generous excision, either bilateral subcostal incision with midline upward extension or right thoracoabdominal incision. Being aware of the site of pathology in the liver loops to assist the accessibility of some procedures we do, ultrasound-guided biopsy or ultrasound-guided pigtail can be used. Morphologically, the liver is divided into a large right loop and a small left loop divided by the falciform ligament. In addition to the presence of 3 fissures on the inferior surface, we have 2 additional loops. The right longitudinal fissure extends anteriorly from the gallbladder to the IVC posteriorly, and the left longitudinal fissure extends from the ligamentum teres anteriorly to ligamentum venosum posteriorly. So we have 2 additional loops, the anterior quadrate loop, which is called segment 4, and posterior caudate loop, which is called segment 1. Regarding the caudate loop or segment 1, it has a critical anatomical location extending between the inferior vena cava posteriorly and the portal vein anteriorly. We identify the caudate loop as a separate morphological loop with a separate blood supply that drains directly into the IVC. And due to its complexity, affection on the caudate loop has an impact on the prognosis of some liver tumors. Liver as a whole is fixed in its position by different elements, such as ligaments, which are the most important fixation element. First, we have the falciform ligament, which attaches from the anterior liver surface to the anterior abdominal wall and extends posteriorly to the coronary ligament. And in the free inferior border, there is ligamentum teres, which is the obliterated umbilical vein. Then we have the right and the left triangular ligaments, the coronary ligament, the gastrohepatic ligament on the inferior border, and the hepatoduodenal ligament, which form with the gastrohepatic ligament, the lesser oment. These are the ligaments that we divide in a bloodless plane to facilitate the mobilization of the liver. As we said, the ligamentum teres represent the obliterated umbilical vein. So it's really important to note that in patients with portal hypertension, this vein can recanalize, so proper ligation should be done. Also, we should note that the umbilical vein is used to connect to the left portal vein, so ligamentum teres is used as a surgical mark to reach the rex fossa and the left portal vein. The hepatoduodenal ligament is one of the most important ligaments, extending from the porta hepatis superiorly to the upper border of the duodenum inferiorly, and contains the portal vein, common bile duct, and hepatic artery. Around this ligament, we perform Pringle's maneuver to make inflow control. Usually, the gastrohepatic ligament is not divided during liver surgery, but if we had to, we should pay attention and be very cautious, as sometimes it may contain the apparent left hepatic artery which arises from the left gastric artery. Moving to the Glisson's capsule, which is a thin connective tissue capsule, and its role is covering the internal anatomy of the liver and the portal pedicles. We should note that the Glisson's capsule, which covers the portal pedicles, is separate from the proper membrane of the liver, which is called the Lennox capsule. This allows us to divide around the portal pedicle and deal with it as a whole through the extraglissonian approach, or to deal with each one individually through intraglissonian approach or intrafascial approach. Besides that, Glisson's capsule allows us to perform an intraoperative mapping of the hepatic vessels, as by ultrasound it shows a hyperechoic feature, so we can separate the portal vein from the hepatic veins during liver dissection. Moving to the internal anatomy of the liver, which is the basics of the dividing system of the liver. Over the years, there have been many classifications and dividing system of the liver. All were based on the internal anatomy of the liver, especially on different structures such as hepatic vein, portal vein, and arterial biliary tree. The most recent and universal dividing system was proposed by the International Hepatopancreatobiliary Association in the year of 2000. They said that the liver is divided into 3 divisions, the first, second, and third division, based on the internal anatomy of the vessels and the biliary tree. The first order division divides the functional right and left hemilivers based on the midplane of the liver, which is called Rex-Cantil line. It's an imaginary line that has no external markings and extends from the left side of the IVC superiorly to the gallbladder inferiorly. And within the substance of the liver, the middle hepatic vein lies on the same plane and courses along the same path. Second-order division divides the liver into sections based on points of the division of the hepatic artery and the biliary tree. The liver is further divided by the intersectional planes. The left one, which corresponds to the umbilical fissure, and the right one, which has no surface marking. As a result, the liver will be divided into a left lateral section, left medial section, right anterior section, and a right posterior section. Also, within the substance of the liver, the right hepatic vein corresponds with the right intersectional plane, and the left hepatic vein corresponds with the left intersectional plane. Coming to the most important one, the third-order division or conveyed division, which divides the liver according to its functional segments based on the principle that each segment has its own inflow, outflow, and biliary drainage. So we have 8 segments, starting from the caudate loop or segment 1, and passing on from the left side to the right side in a clockwise pattern. Morphologically, the liver can be divided with its segmental anatomy by 3 vertical lines corresponding to the major hepatic veins. Furthermore, it's divided into upper and lower segments by a 4th transverse line, which is at the level of portal vein bifurcation. Segmental and sectional anatomy is very important to be kept in our mind. As with radiology, we can localize the liver pathology, and that will help us plan the anatomical surgical resection based on internal anatomy. Also, segmental and sectional anatomy can be used as a grouping system, such as the pretext grouping system of hepatoblastoma. With the concept of unification of the dividing system, the liver resection terms are also unified. So if we resect the right hemiliver, it's called right hepatectomy or right hemihepatectomy. And for left hemiliver resection, it's called left hepatectomy or left hemihepatectomy. And for each, we should mention if we resect the caudate loop or not. If we resect the sections, then it's called sectionectomy, and the more accurate term for this is trisectionectomy. After mobilization of the liver, now we are dealing with vascular and biliary tree anatomy. The liver is a highly vascular organ with a double blood supply in the form of the hepatic artery, which represents 25% of the blood volume, and the portal vein, which gives 75% of the blood volume. The hepatic artery proper is considered a continuation of the common hepatic artery, which is a branch from the celiac trunk. This arterial system is the main arterial blood supply in 60% of cases. The hepatic artery proper is found in the medial aspect of porta hepatis and divides into the right and the left hepatic arteries. The right hepatic artery divides into the right anterior branch, which supplies all the anterior section, and the right posterior branch, which supplies the posterior section. While the left hepatic artery divides into the left medial or middle hepatic branch, the left lateral supplying the left section, and the branch to the caudate loop. In the other 40% of cases, there are some variant patterns, but it's important to differentiate between the accessory vessel and the replaced vessel. The accessory vessel is an additional vessel to the original branch, while the replaced vessel is the only blood supply to the loop in the absence of the original vessel. There are many variations and classifications. The most noted is type 2, in which the left hepatic artery arises from the left gastric artery, and type 3, in which the right hepatic artery arises from the superior mesenteric artery directly. As we said before, the importance of all of that is identification, as the left apparent hepatic artery can be found in the gastroduodenal ligament, so if I have to divide it, I should be cautious. Regarding the right hepatic artery, we have mentioned that the hepatic artery is normally located in the medial aspect of porta hepatis. If it is apparent, it will be found in the posterolateral aspect, so it can be injured during dissection if we haven't noticed the variation. This can be avoided by proper preoperative imaging. Moving to the portal vein, which is formed by the union of the splenic vein and superior mesenteric vein. And in 30 to 40% of cases, the inferior mesenteric vein joins this confluence. The portal vein is found in the porta hepatis as the most posterior structure behind the hepatic artery and the common bile duct. As we can see, the portal vein is divided into right and left branches. The left branch has a longer extrahepatic course and is transverse in course, while the right branch has a short extrahepatic course and is mainly vertical. This right branch is further divided into a right anterior branch and a right posterior branch. This normal branching is found in 65% of the general population. In the rest, there are some variants. The most important one is the trifurcation of the portal vein, in which it's divided into the left portal vein, right anterior, and right posterior directly without a right stump. Or we can have the right posterior segment arises directly from the main portal vein, or the right anterior branch arises from the left portal vein. Regarding the trifurcation of the portal vein, its value appears in the liver transplantation. As we said before, the portal vein normally gives a stump, then it's divided into left and right, and the right gives anterior and posterior branch. In trifurcation, there is no stump, so it will appear only as two openings regardless the left portal vein. And for example, if we are doing right hepatectomy, on the back table we should perform reconstruction to these two openings into one opening, as we are going to give the recipient a one opening. So this variant should be assessed preoperatively to manage the time of the reconstruction. However, this practice is contraindicated and very difficult to perform. Passing out to the biliary anatomy. The general biliary tree corresponds to the segmental anatomy in the form of segmental ducts. Then we have sectional branches, and then we have hemiliver branches. Regarding segment 1, part of its complexity is that in 80% it drains the right and left hepatic ducts, 15% only to the right duct, and 5% only to the left duct. We should mention that there are no collaterals, they are terminal branches. So we consider that every segment in the liver acts as an individual liver. Talking about extrahepatic biliary tree, we have the right and left hepatic ducts forming the common hepatic duct, which joins the cystic duct anteromedially forming the common bile duct. The common bile duct is in the anterolateral aspect of the porta hepatis. The right hepatic duct has a short extrahepatic course and is vertical in orientation, while the left hepatic duct has a longer extrahepatic course and is horizontal in orientation. There are a lot of biliary tree anomalies, starting with the segmental anomalies, which have no surgical importance, moving to the sectional anomalies, including the right posterior duct, which is the most seen variant, the right anterior duct, and the left hepatic duct, which is the least seen variant. Also, we have biliary confluence anomalies and cystic duct anomalies. To make it easy, we are only going to talk about confluence anomalies, which are the most important. Type 1, which is normal. Type 2 is trifurcation, which means that the common hepatic duct gives way to the left hepatic duct, right anterior, and right posterior directly, also without a stump. Type 3A, right anterior from the left hepatic duct. Type 3B, right posterior from the left hepatic duct. Type 4A, right anterior from the common hepatic duct. And type 4B, right posterior from the common hepatic duct. So before any complex surgery or liver transplantation, we should do MRCP, which stands for the magnetic resonance cholangiopancreatography and intraoperative cholangiogram. Recently, indocyanine green has played a great role in showing the biliary tree intraoperatively, but unfortunately, it's not that much available. Last but not least, we are going to talk about the inferior vena cava. During liver surgeries, we deal with suprahepatic, retrohepatic, and infrahepatic IVC. The suprahepatic IVC usually drains in the right hepatic vein, middle and left hepatic veins as a common trunk. This represents 60% of the cases. In the rest, each vein drains separately in the IVC. In some cases, the right hepatic vein is small and is compensated by the presence of a large right inferior hepatic vein, an accessory hepatic vein, or a well-developed middle hepatic vein. We should mention that it must be anastomosed during transplantation, as whenever the graft outflow is good, the outcome will be great. So it should be assessed preoperatively using venography, and if not, it will result in graft congestion. Regarding the retrohepatic IVC, it's exposed by liver mobilization and optimal left rotation. Then we dissect the right lateral surface of the IVC from downward to upward to be separated from the posterior surface of the right hemiliver. Then you will see the short hepatic veins that should be properly ligated. The number varies from 5 to 20. Besides, in 20% of patients, we can see a large inferior hepatic vein, which also should be properly ligated. During dissection, we see the right hepatocaval ligament or Makuchi's ligament, which bridges the lower part of the right hepatic vein. This ligament should be released using Makuchi's technique, as this fibrous ligament sometimes may help small veins that should be ligated, And as we said, we should release it to expose the right hepatic vein, which in some cases may be absent. If we are dissecting on the left side, we see the ligamentum venosum, which connects the left hepatic vein to the left portal vein. So it also should be released to make a proper exposure to the common trunk or the left hepatic vein, helping in loop isolation. Sometimes infrahepatic IVC needs exposure and control, as it reduces bleeding during hepatectomy. And if we perform infrahepatic IVC control, we should pay attention to the left adrenal vein. And finally, we have reached the end. Thank you for your time. Hope you have enjoyed the lecture.